Good evening to you all, dear participants. Let me start by saying good morning, good afternoon, and good evening to you all from wherever you are listening to us from. Thank God for technology. We are able to connect from all walks of life. Welcome to the asthma training. We would want to begin with an opening prayer. So please, anybody led by the Spirit can pray for us to begin the program. Thank you. Any volunteer, please? Okay. Okay, since there's no volunteer, let me pray. Our Lord and Master Jesus, we thank you for such a wonderful gathering. We have gathered here in your name to learn, to be equipped, and to impact society at large. We commit our training into your hands, that whatever we shall discuss here shall be a blessing to us and to mankind. We commit our facilitators into your hands, that you lead this discussion and it shall come to a fruitful end. In Jesus' name I pray. Amen. Welcome once again to this evening's training session. Our program is starting any moment from now. I want to know if Dr. Iseku is on the line, please. Madam, please, are you with us?
Yes, I'm here.
Okay, thank you. Please, can I hand over to you now?
All right. Thank you very much.
Welcome, madam.
Thank you so much, Dorcas, for the opening prayer. And I would also like to say a big welcome to everybody for joining us. Thank you for taking time to join us. We at the Ghana College of Pharmacists believe that it is important for pharmacists to be skilled in all that they do. And so we take time to design programs to collaborate with partners who believe in this vision to bring training programs to pharmacists. And one of them is this our asthma training program, which, as you can see, we are saying you should master. The idea is that you master asthma management. So we've put together facilitators from amongst our midst, but well seasoned and really experienced facilitators to help us delve into asthma management. But we don't just want to discuss what asthma is and also how, as pharmacists, we can contribute to the management of pharmacists of asthma in our community. We want to take it a step further and we want to also master the devices so that if our community members come into our facility or we meet them anywhere and they need support in how to effectively use their devices for optimal results, we as pharmacists are equipped, we are confident, we are competent to provide that support. And so our facilitators, as we have said, are experienced. They know what they are about. And I will urge each one of us to pay attention to this evening session and also remember to be present early for tomorrow's sessions, whether you have registered for the morning or for the afternoon. We expect that when we have finished everything, each one of us will be competent and we will be confident to provide the support that is needed by our community members in handling asthma cases that are brought to their facilities. And so, on that, I will say once again, welcome. Let us all be present. Let's pay attention. Let's enjoy the new knowledge. And together, let us scale ourselves even more. Thank you. And I'll hand over back to you, Dorcas, to continue.
Thank you very much, madam. After this program, pharmacists will be able to have the knowledge about how to educate patients on asthma, phytophysiology, and medication regimen, provide personalized instructions on proper inhalation techniques, address concerns and mitigate fears regarding potential medication side effects, and finally, to enhance patient adherence to therapy, fostering improved healthcare outcomes. So, not wasting much time, I would like to invite the first facilitator, who is a foundation fellow of this noble college. She is Dr. Mrs. Amma Nkansa, but popularly known as Auntie Amma. She is a consultant clinical pharmacist and a fellow of the college, as I've just said. She is currently the acting director of pharmacy at Kolebu Teaching Hospital and has about 30 good years of working experience in hospital pharmacy, academia, healthcare administration, and research. So, ladies and gentlemen, help me welcome Auntie Amma, Dr. Mrs. Florence Amma Cancer, to, to take on. Thank you. Auntie Amma, we are all ears.
Good evening, everybody.
Good evening, Auntie Amma.
Good evening.
Please, can you hear me?
Yes, please.
Can you hear me? Okay. Thank you very much. And I want to thank the rector to take you on understanding pharmacy, understanding asthma in the pharmacy setting. We are two on the call today. So my colleague Victor will take the other aspects. And so I will just start off so that he continues on the use also of the inhalers. Can you see my slides, please?
Yes, please. We can.
Can you see my slides?
Yes, please, we can.
Okay. Thank you very much. Good evening again to everybody. Okay, so I'm going to be presenting on understanding asthma in the pharmacy setting. Okay, so what is asthma? My outline is going to be in this format. I'll look at the epidemiology, types, pathophysiology, symptoms, diagnosis, and treatment. So, what is asthma? Asthma is known as one of the major affecting people of all ages, particularly children, adolescents. So it affects all adults, adolescents, and children. And it's particularly common in also in children. And it's known as a common chronic disease in children. It is a common and potentially serious chronic disease that imposes a substantial burden on patients, their families, and the community. Globally, more than 262 million people are affected with asthma, and that has caused 455 deaths. This is reported by, it was established by WHO in 2019. Most asthma related deaths occur in low and lower middle income countries where underdiagnosis and undertreatment is a challenge. I must say that in asthma, we have underdiagnosis, undertreatment, and sometimes overdiagnosis being a very big challenge. And I'm sure as we go through the slides, you see it. And amongst adults, women have a 30% greater prevalence of asthma than in men. So, what is asthma? Asthma is a heterogeneous inflammatory disorder. In fact, I must say asthma is a complex chronic inflammatory disease. So most of the time we want to find out what asthma is. Sorry. It is usually a complex chronic inflammatory disease that affects the airways. And one thing I want us to take away today is that it is characterized by chronic airway inflammation. If you get that throughout the presentation, I'll be very happy today because that's the base, the hallmark of what we are doing today. Okay, it is characterized by chronic airway inflammation, and I believe that if, as you see the airway inflammation, you'd also be concerned about the treatment we're going to use also for treating asthma. It is also defined by the history of respiratory symptoms such as the wheeze, Most of the time, it's a recurring wheeze, shortness of breath, chest tightness, and cough that vary over time and intensity together with variable expiratory airflow information. And asthma is usually a result of interplay between the genetic and environmental factors, so it is really, really complex, and we'll see that. So understanding the pathway is it's not really clear. I mean, the pathway of asthma is not really clear because it involves the genetic and environmental factors. And as we go along, you see it. I've said it's a heterogeneous disease, and there's chronic inflammation of the airway associated with airway hyperresponsiveness and variable airflow obstruction. That's very common that we need to know. Like I've said, it has recurrent episodes of wheeze, shortness of breath, tightness, and that would vary over time, vary in intensity, and vary in frequency. So you realize that the intensity, the frequency, and the occurrence would determine what kind of asthma the patient has. Now, you realize that there are a lot of tablets you see on the right there, and that is because most of the time we see asthma, or it is not usually treated most of the time chronically. You see it as a recurrent acute disease. So when people get the acute disease, they treat it, and afterwards, oh, I'm fine, and they go and rest. And so that is because it is not properly treated. That is why we really have a problem that comes up. And it causes, or it has a burden to the parents, the family, the health system, the economy, and the patients. So when a patient has asthma, you realize that everybody is involved in treating that patient. There's a risk of asthma mortality also with it. And there's usually a cumulative risk of adverse effects of oral corticosteroids within 4 to 5 lifetime courses. Because most of the time, when people get the acute episode, recurrent, they just go for the tablets and then that is it. When they are fine, or they go to the hospital and they're admitted in the emergency department, when they are fine, they just go back, and relax and don't take anything. And we'll see that as we go along, why it is very important that it should not be treated as a recurrent, only acute disease, but it should be treated alongside. Okay, asthma morbidity and mortality are largely preventable. So we don't want our patients always going into the emergency, as they get episodes of it, but we want to make sure that our patients are treated very properly. And as they are treated properly, you realize that there's a long span for the patients, and we hardly get a mortality with the asthma patients. So what are the types of asthma that we usually have? There are two main types of asthma, and I want us to take note of it. Even though we have other types of asthma, the main types are usually two, which is usually the allergic induced or the non-allergic induced. Okay, so let me start with the allergic. So it is complex disease caused by multiple factors, and there are two main types of asthma. We can also have the mixed asthma that could also be the allergic and the non-allergic. We could also have the exercise induced, which we usually have with the children, and we'd also have occupational one, which would also have with people who are allergic to some of the at work, okay, depending on where they work and what they are allergic to. Some of them are allergic to dust, some of them when they work in the factories, wherever they are. So we have that coming up a lot. Okay, so you usually have the allergic one. The allergic one is usually caused by, it's also known as atopic, and it's caused by either house dust mites, cockroaches, molds, allergens, mainly most of the time. And this is a very popular one. It could be food allergens, any of them. And you realize that what happens is that when the symptoms are induced, these are usually when the symptoms are induced by the hyperimmune response of inhalation of specific allergens. So depending on what the allergen is, and in asthma, we always say that you identify your trigger points and make sure that you are able to identify whatever allergens are causing the asthma. It is very important that those are identified very, very well. The trigger factors are identified so that you can avoid them. So you realize here that most of the time what happens here is that the allergen is what is going to, or the atopic here, mainly most of the time, is what is going to induce this asthma in the patients. Okay, so we are looking at the immediate hypersensitivity reaction, which is usually caused by the immunoglobulin E, And this would usually tend to have, you realize that in these patients, there's a positive history also of asthma. And most of the time, this positive family history is of allergic diseases. That is why I say you need to identify it. And that could be by, you identify them sometimes in patients who have eczema or patients who have also rhinitis. So with the allergic one or the atopic one, we should be very careful because these are usually have a family history, of allergic diseases. So most of the time you realize that we would ask. So we also realize that with the allergic one, in the allergic asthma, what happens is that this patients, again, they usually most of the time have any kind of some kind of asthma or allergic asthma that is also induced by challenges also and mediated also by the immune response system. That is very important that we know. Now, when we come to the non-allergic one are usually the irritants that stimulate the parasympathetic nerve fibers in the airways. And most of this time, you realize that these are usually non-atopic or non-allergic. So these type are usually triggered by irritants in the air, and they are not related to allergens. So with the non-allergy, you see things like cigarette smoke. When people are exposed to cigarette smoking, they go to a place where the cigarette smoking, so the exposure there, the diesel particles, it's not doing of theirs. They happen to be around and this happens. Sometimes you have infection, and mainly these are usually viral or bacterial infection. Exercise, okay, they could be formed as any exercise, okay, but we'll see more of the exercise induced ones that happen more to children. It could be cold air or also hot air. So you realize that these are things that would also stimulate patients. These are usually characterized by the late onset, okay? So because they are not allergic in nature, these are usually characterized by late onset of asthma. But in the allergic one, you have that those usually have a family history of asthma. Now, with the non-allergic one, again, another thing you need to note in this one is that, like I said, they are irritants. And depending on where you work, you could have some of these also affecting it. These are usually triggered by factors not radiated to allergens, okay? And so anxiety, stress, exercise, cold, dry air, all of that is usually smoke, mainly most of the time. Sometimes even some people, it's even with perfume. So you realize these are people also, as soon as they get to a place where somebody is sprayed some perfume, they also have challenges coming up with that. And we need to take note of that where we have the non-allergic and or topic and then the allergic ones. I also said that we can have the mixed one. The mixed one is just a combination of the allergic and non-allergic. And also you could have the exercise induced one, and that's most of the time occurs with children as they go to play. Before they go to play, you realize that as they start having their exercise, it is induced. And then also you have the occupational one that you can have about 15 to 25% of human beings also having the occupational one. So you need to, as I said earlier on, identify your trigger factors because those are very important. If they are not identified, then it means that you cannot avoid them. We have people here in the hospital who work maybe in the stores, and you realize that they come up and they always have asthma. You just have to change their working places. So those are induced by triggers that exist in the person's workplace. Sometimes textile industry, farming, woodworking is also very, very common. And like I said, you have 10 to 25% of adult onset asthma. And that's sometimes very difficult to diagnose because if you do not take a good history, you will not be able to know. So when the person always gets into a workplace whereby asthma is always triggered, then you want to take note of that and deal with that and treat that patient. I've talked about the exercise induced that affects persons usually after a physical activity. And then also the mixed one, we could be a combination. So, okay, sorry. Okay. So now we want to look at the pathophysiology of the pathogenesis of asthma. Like I said, it's a complex respiratory condition that can be managed in a pharmacy facility, okay? And you need to know how this is done. This is really complex, but main thing you want to look at in the pathophysiology is that there's airway inflammation, there's airway hyporesponsiveness, there's bronchial airway remodeling, there's bronchial smooth muscle constriction, and there's also increased mucus production. So you have the antigen presentation by the dendritic dendritic cell here, and most of the time that the antigen presentation by the dendritic cell with the lymphocyte and cytokine response will lead to airway inflammation like you see here, and you also see the asthma symptoms also here. But most of the time what will happen is that there are usually some key things, like I said, that you always want to look at, and that is usually the airway inflammation, which is usually very common in such patients. You also want to look at the airway hyporesponsiveness. You also want to look at the bronchial airway remodeling, and you also want to look at the bronchial smooth muscle smooth muscle constriction. Okay, so these are very important things that you want to look at. Now, what happens in the airway inflammation? Most of the time in the airway inflammation here, you would realize that there is usually, which happens most of the time, there is usually the activation of the immune cells. You have the T cells, the eosinophils here, and then the mast cells, which releases, the inflammatory mediators. Okay, and these inflammatory mediators, like you see in the cytokines and the chemokines and the histamines, they will attract and activate the human cells, okay, the immune cells here. Now, with the hyperresponsiveness, most of the time what you see here, it is usually characterized by exaggerated response to stimuli, leading to bronchospasm, and that will lead most of the time to airway constriction, which we usually see in the patient, and airway resistance. Most of the time, you also have the airway remodeling. That usually has to do with the structuring changes, okay? So most of the time, if you have an allergen, always maybe a new one just coming up and it causes some structural changes, then you need to look at that, because it always changes the airway wall. It will cause smooth muscle mass and deposit collagen, and also would lead to persistent airway flow. You can see this very well in the cells, in the muscles here. This is when you have somebody having asthma during the asthma symptoms, what happens, and when you have somebody just a normal airway. Now, most of the time also, you also have the, like I talked about earlier on, the immunoglobulin E and the allergens. Most of the time when you have that allergen coming in and the dendritic cell with the, that would lead, that is presented, the antigen presents with the dendritic cell, that would lead to lymphocyte and cytokine response, okay? And most of the time, these are very important. You need to know the cytokine and the chemokines also that regulate the immune cell and also cause differentiation. We also want to know about the immunoglobulin, which is really very important when it has to do with atopic asthma, because that is very, very key. And you also want to know the airway smooth muscle that happens here. You see it here, whereby there's constriction. You also want to know about the inflammatory that happens here that leads also to this thickened air wall. And you also find the tightened muscle also that constrict the airway, and the narrowed airway, which is limiting the airflow here. So in the asthma patients, all these go on. We have the airway smooth muscle that is constricted. You have the epithelial cells there, which has to do with the allergens. You have the immunoglobulin E presented there. All of these go on to cause, trigger factors in the patient, and then you realize that the patient presents with asthma. This is what I want you to take note of, looking at the airway cell, the normal airway cell, and also looking at the thickened airway cell here, whereby there's mucus production, massive mucus production here, and you have the obstruction of airflow here. So you see that the constriction of the airway is tightened and is very small and causing airway flow there to be limited. That is very important. So you want to look at the trigger factors, and most of the time the trigger factors, as I said earlier on, will be allergic trigger factors or non-allergic mainly. Now, trigger factors are things that you have to identify that would stimulate the asthma, and that is very important. You can have allergens of different types. You could have allergens, some will find them in food, And you need to be careful, especially when it's in food. It's very, very bad, because you really have to take notes to really identify what it is that causes that allergic trigger. And it's very important. Some people just take cashew nut and it's big trouble for them. Okay, and that is why you have to go for a test. Okay, the skin test, to be able to identify what could trigger that factor. Some just have dust mites, cockroaches, I mean the pollens, the molds, feathers, animal fur, and can be very bad for those who are allergic to a lot of things. So as they enter a room and they feel some of these things or they see them, it triggers the asthma in them. The non-allergic trigger factors are usually irritants, like I talked about earlier on, and smoke, temperature changes, certain air pollutants, and chemicals. Some of these could also cause, some of the asthma and the asthma that we have finding in patients. There are others, and the others could be flu, influenza. I talked about it earlier on, viral disease, bacterial diseases. The popular one is the RSV, sinus infection. So you could have people with eczema, you could have people with rhinitis, and all of them. It just aggravates the asthma that the patients present with. Okay, so it could be respiratory infection, that could be viral, bacteria, air pollution, that could be, from smoke, could be exercise or cold, variations in temperatures. It could be also stress and emotional factors. So you need to look at that and find out what it is that triggers your asthma. Identify the trigger factors, very important. So it is very important that we get to know that there are also other triggers, and these other triggers could be patient-specific triggers. So you could do all that you can concerning the allergic and non-allergic triggers, but if you do not identify the patient-specific triggers, then you realize that you'll just be going round a circle. Some of them I've talked about earlier, the upper and lower respiratory tract infections. So if you have an infection, that could also trigger that asthma that the patient has. So most of the time when you're looking at the symptoms, you need to look at that very well and find out whether some of the symptoms you have is a cold. Okay, is it a cold that the patient has? Do you have an infection? Do you have a pneumonia? That is very important that we identify, because that could be really sometimes not asthma, or it could be another disease condition. Over reliance on salbutamol and other bronchodilators, very important. We'll get to that as we look at the treatment. Poor patient technique in the use of inhaled medications, and I believe Victor is going to talk about that, and we'll delve into that tomorrow. Lack of inadequate use of inhaled corticosteroids. Sometimes it's due to the cost, so the patients don't want to use it, and they rather would stick on to oral corticosteroids. You realize that all throughout we are talking about inhaled corticosteroids and not the oral corticosteroids. The oral corticosteroids have a place, and we'll talk about that later. Poorly controlled asthma, and that could determine in the patient if you see the exacerbations in the patient, and that is when the patient comes up with this, after they've been to the ED, you realize that there's the emergency department, they still have episodes of progressive increase in shortness of breath. Even after they've been treated, they still have the progressive increase in the shortness of breath, the cough, the wheezing, and the chest tightness, and some combinations of other symptoms accompanied by the decrease in the expiratory airflow. Okay, so you realize that even though you keep on treating, these are patient-specific triggers that could worsen the asthma, and also poor compliance with asthma medications. If the medications are not taken properly, the right medications are not taken, will still have the trigger factors. So you have somebody not being treated properly because they are not adhering to their medications, they are not using the right inhaled corticosteroids, the asthma is poorly controlled, and they're always using salbutamol as for treatment and nothing else. All they take is just the Salamol or the salbutamol, and they have issues with that. So it is very important that we identify what the trigger factors are and know how to treat it. So what are the investigations we would usually go out for, or that will be done for us or for the asthma patients? It's usually the full blood count, mildly high eosinophil count should be greater than 4%. Then the chest x-ray. Now the chest x-ray is just to rule out any other disease condition, maybe pneumonia or any other infection that the patient will have. But the chest x-ray is not an investigation that is done really for asthma. It's actually to rule out any bacterial disease or any other disease the patient is likely to have. We have the spirometry. The spirometry is the equipment or the test that is done to confirm diagnosis of asthma, okay, to confirm asthma diagnosis. So you realize that this spirometry is not usually done in a lot of institutions, and that is very important that it is done, because that will confirm, or diagnose the asthma that the patient has. And that is usually important when the patient has the symptoms. If the patient is very well and you go to do this test, you might not necessarily get a response or any good feedback. But if especially if the patient is asymptomatic, but when your patient has the symptoms and you go, it will tell whether there is airflow obstruction. Now, the peak expiratory flow rate measurement is usually used for monitoring the patient, and that is very common, and that is not used for diagnosis, but it is used for monitoring. I'm sure we'll look at that in the next presentation. And then because we're talking about a lot of allergic, asthma, there's a test for atopy, okay, to the allergen, to find out the specific immunoglobulin for that common allergen that the patient has. It's very important. The allergen testing that is done is also done in some of the institutions, and that could also be performed by skin test or usually blood test. And it is usually mapped with a list, and that would usually tell you where you fall. And it helps you also determine some of the allergens you would react to, or that will aggravate your asthma. So it is very important that this is done, especially for patients who do not do well. Now, stool examination. The stool examination also will just exclude helminthiasis, because sometimes you find worms also in the lungs, and it will give you this wheezing sound, and you think that you have asthma. So that is also done to exclude worms. Now, what are the common symptoms that we see in the patient? Now, I talked about the recurrent wheeze. You would usually have a cough at night, and you would usually have dyspnea, that is shortness of breath, and or tightness in the chest, and then you have a chest pain. So the tightness in the chest, very, very important. The wheezing, that is very important. So those are the symptoms that you see: shortness of breath, the cough you usually find at night, recurrent wheezing, and also the chest pain that you usually find in these patients. Now, for the objective or the signs, you usually find tachypnea, that's tachypnea and tachycardia, okay? And then you have hypoxia, and you have the as accessory muscle use, and the intercostal retractions, and also the expiratory wheeze. So these are the signs. This will be used to determine what the patient has. What is it that the patient has? This will be told by the healthcare professional, usually the doctor, that will be able to identify what the patient has, and that would confirm the asthma that the patient usually has. So when you are diagnosing asthma, like I said, either overdiagnosis, because sometimes what you are doing could not be asthma, it could be even something else you are dealing with, or underdiagnosis. If you're not doing the right test to actually diagnose the disease condition, you might miss it. You might miss it. And also, under treatment is also very common, because if the patient is not treated properly, and then you realize that you've missed it. So we have respiratory symptoms that are often non-specific, and those are usually the ones for dyspnea, shortness of breath, and cough, okay? So you realize that there are a lot of differential diagnoses for dyspnea and for cough. So you need to be very careful that you are treating asthma or no other condition. Now, globally, most physicians do not have timely access to spirometry, like I said earlier on. And so even in the high income countries, so you need to be careful. You need to take a very good history, identify it, and then make sure that you fill your action plan, and then assess your patients properly so that they will be treated properly. But it is very good to have a spirometry done to be able to, to diagnose your asthma. Like I said, we also have the peak expiratory flow meters, which are less reliable than spirometry, but they are used for monitoring your patient. So you want to use your peak expiratory flow meters if spirometry is not available. But again, like I'm saying, that would really continue, why we better look for better diagnostic tools. But that is not really the treatment or for diagnosing asthma, and that must be noted very clearly. that you need to diagnose asthma very well. And that will be very good for you and your patients, the family, and everybody. So, what are the key diagnostic features that we look at? Asthma is a disease with many variations. I said it is a complex disease condition earlier on when I talked about it. It is heterogeneous, usually characterized by chronic airway inflammation. So the two main things here is the airway inflammation or airflow limitation, like I said earlier on, which you have here, and also the respiratory symptoms that vary over time and intensity. And the respiratory symptoms I've talked about here are the wheeze, cough, shortness of breath, and the wheeze, cough, the shortness of breath they are usually likely to get in the patient, and also the cough at night. Very important that we look at that. Okay. So what is the initial diagnosis? Now, when you have a patient who presents with the wheeze and the shortness of breath, the tightness or the cough, what you want to look at is to find out whether this is really asthma. And those are the respiratory symptoms that you want to look at. Are they acute or chronic other than asthma? Because other disease condition can present like that. Like I talked about helminthiasis, okay? When you have worm in the lungs, that could lead the patient to wheeze. But again, that occurs mainly in children, but you want to, with children, it is really sometimes very difficult to be able to tell, but you want to look at all of that and find out. So if you have, and this is usually typical of asthma, if you have more than one symptom, that is the four cardinal ones we talked about. That is the wheeze, shortness of breath, the cough, and the chest tightness. If you have more than one, especially in adults, then that can be asthma. But again, you want to do further investigation. Most of the times, the symptoms worsen more at night or early in the morning. You want to look at that again. I said earlier on that the symptoms vary over time and intensity, depending on it. If you are treating the asthma, you have more trigger factors setting in, and you're not avoiding them, you could also increase in the intensity also there. They are also triggered by viral infections, which I talked about earlier on, exercise, allergen exposure, changes in weather, laughter, all of that. The non-irritant ones also could worsen it. So it is very important that asthma is diagnosed properly. Sometimes people just get the cough and they think that that is asthma. You want to do further investigations, and that is why the spirometer is very important to be able to tell or identify it. Now, most of the time, when you say it is not asthma, it means that if you find an isolated cough with no respiratory symptoms. So it can be ideal that you could find in an adult just an isolated cough, but you want to investigate and find. But if there are no respiratory symptoms, it might not be asthma. So you want to take note of that. Chronic production of sputum might not give you asthma when you're just producing that. You want to look at the respiratory factors and you want to look at the airflow obstruction. Shortness of breath is usually associated with dizziness, lightheadedness, or peripheral tingling, might not also be asthma. You want to take note of that. Just a single chest pain might not be asthma. So it is very important that we get all the factors very well, the features very well, to know whether that is respiratory symptoms we are seeing or anything that will cause the airflow obstruction. That is very important. So if you have an exercise-induced dyspnea with noisy inspiration, it might not be asthma. So look well for asthma to be able to treat it. Now, most of the time when you are diagnosing a patient with asthma, which is usually done, you would find that, again, I've been stressing on the four cardinal symptoms, and I hope we are taking note of that. The wheeze, the shortness of breath, the chest tightness, and the cough. And this could vary, and especially in children, you could have heavy breathing with that. Generally, if there's more than one type of respiratory symptom in the asthma, like I said, the isolated cough alone would not give you asthma. And you need to look at that. We've talked about this. So you should know that the symptoms often appear, but they could worsen also with viral infections. Now, to diagnose asthma, I've talked about that you want to use the spirometer, which you use in diagnosing asthma, very important. And in that, all you're trying to do is to look at the forced expiratory volume in 1 second of that the patient is able to blow very hard into the spirometer, okay? And you want to look at the forced vital capacity also that will come up You want to look at that also, that as the patient blows over it, the ratio of that, which is usually reduced, would tell you that this is asthma in the patient. But if it is more than 7.5 or 0.8, it means that there's no airway obstruction, okay? But in children, you would find that that is usually more than 0.9, and in the adults, it's usually 8% or 0.8 or 0.5. That is very important that is done. You could also have the bronchodilator reversibility, which is done in the patients. And so these are diagnostic features, many that are done in hospitals to be able to confirm the diagnosis of the patient. Very important that we note that also. Now, if you're looking at differential diagnosis, like we talked about earlier, you want to look at the various ages. What are the common diagnoses, differential diagnosis you would see in a suspected asthma patient? And most of the time in the children, if you see sneezing, itching, blocked nose, throat clearing, it could be a chronic upper airway cough syndrome. If you see sudden onset of symptoms, unilateral wheeze, it could be an inhaled foreign body. If you see recurrent infections, productive cough, I'm bringing this all up because they will present sometimes in our community pharmacies, and we must take note of that. If you see recurrent infections, productive cough, it could be bronchitis in the patient. If you see congenital heart disease, most of the time might not see that in the pharmacy. They might present with cardiac murmurs or and the rest, okay? So excessive cough, mucus production, gastrointestinal symptoms, those are to be noted properly in children. Children present with a lot of gastrointestinal symptoms, and we must take note of that to be able to identify asthma in a patient. Most of the time in the adolescents, they could also present with the upper airway cough syndrome, and you see all the symptoms that they present with there. And you need to take note of that if they inhale a foreign body. Very important. With the adults, it is, like I said, a single cough, isolated cough could not be asthma if you don't have the respiratory symptoms. So you also want to look at that. What is it that will present in the patient? And I must mention the pulmonary embolism, which is also very common, because you see sudden onset of dyspnea and you have a chest pain. But again, even though there's a sudden onset of dyspnea and a chest pain, they could also sometimes present with a cough. So you want to look at the other clinical symptoms that the patient will present with and be able to confirm the diagnosis of asthma in the patient. And if the patient has dyspnea, is unresponsive to bronchodilators, that could be a COPD, and you want to look at that. If the patient has a cough, sputum, dyspnea on exertion, and he smokes, also you want to look at that. So it is very important that you note the symptoms that the patient presents with to be able to confirm if a spirometry is not done on the patient. So what is the asthma diagnosis? I must say here that earlier on I said that the hallmark is reversible airway obstruction. So what you're looking here is more of inflammation, and the patient, there's an increase most of the time. The spirometry increase in the forced expiratory volume is usually after you've done the BD, the bronchodilator exposure. You'd have more than 12 or more % after treatment, and that helps you to diagnose whether you want to decrease treatment or whether you want to increase, okay? Whether you want to step down or you want to step up the treatment in the patient. That is also very important. When you have these results of your peak expiratory flow meter, you have your spirometry, which is done, is also carried out. That will help you. Are you increasing the dose? Are you stepping down? Are you stepping down or stepping up treatment in the patient? Are you continuing with your bronchodilator? Are you going to continue also with your bronchodilators for the patient, or you want to give your controllers? They are very important that we get to know all of this. That is why the diagnosis is important, and you need to know what the results are. So this is very important if this is done in the patient. So the diagnosis spirometry should be performed when the patient is symptomatic. I said that earlier on. Otherwise, the results may be normal in the patient. Now, what is the goal of asthma management? The goal is we must be looking at that as pharmacists, and all you want to do is to achieve the best possible long-term asthma outcomes in the patient. We don't want them coming out into the emergency all often, but we want long-term asthma outcomes for each patient. So your long-term symptom control is that you have no asthma symptoms. There's no sleep disturbance. They sleep well and they are not coughing at night. You want to make sure that they don't have any exacerbations. You want to make sure that they are always monitoring their lung function. You want to make sure that there's maintenance, no need for oral corticosteroids for maintenance. I want to stress that again, no need for oral corticosteroid for maintenance in our patients. And you want to note the medication side effects. Of course, if you are taking an AC inhibitor that is giving you a cough, you want to know that that is a cough you are getting from that. But this cough usually will occur at night or early in the morning. So you need to know, have an idea of what the symptoms are and what your goal of treatment is. What are you aiming at in the patient? Now, there's this 4 simple question asthma assessment tool that is usually used. And the GINA assessment asthma control tool here helps us in the adults, adolescents, and children. This is to know how your asthma is being controlled. So in the past 4 weeks, that is what your doctor will usually ask you, and I believe the pharmacist can do so. You want to find out from the patient whether they've had daytime asthma symptoms more than twice in a week. Now, if they've had that more than twice in a week, then it means that you want to look at that as one of the asthma control levels you're looking at. Now, any nighttime waking due to asthma, you want to look at either yes or no. Do you have SABA? And when we're looking at SABA here, we're looking at salbutamol, which is a reliever for symptoms. Are the patients being relieved with their SABA for symptoms more than twice in a week? Now, you want to look at that, whether it's yes or no. Any activity limitation due to asthma. So any activity that would limit them due to asthma, if they exercise and the asthma is triggered, if they go to swim and the asthma is triggered, it means that they have it. If they walk for long distances and the asthma is triggered, if they are running and asthma is triggered, then you want to note that, is it yes or no? Now you can say your patient is well controlled when they respond no to all of this. So none of these symptoms presents. Now, when they are partly controlled, then they have 1 to 2 of these symptoms. And when they're uncontrolled, it means that they have daytime asthma symptoms more than twice in a week, nighttime wakening and asthma. They use the reliever for more than twice in a week. And anytime they go on, they have the asthma or they go on any activity, it triggers the asthma. So any activity limitation due to asthma. So if they have all of this, it means asthma is not well controlled or is uncontrolled. It's partly controlled when you have 2 of these symptoms being present, and it's well controlled when none of them happen within the past 4 weeks. This is very important that we note, because this is what we can use to ask our patients to be able to know whether they are being monitored properly. So what are the possible reasons for poor asthma control? Not using the right asthma medication to treat your asthma, inadequate use of the inhaled corticosteroids, not oral, being exposed to trigger factors causing breathing problems, over-reliance on your rescue inhaler, that's your salbutamol, not adherence to therapy, and that happens a lot with the asthmatic patients. When they see they are fine, then they stop all medications and they do not adhere to them, and they come back later on in the emergency department, and that could lead to mortality. Not following a personalized asthma action plan, and Dr. Prof. would talk about that in the next presentation. So what are your goals of therapy you're looking at in treatment? You want to reduce the impairment and you want to reduce the risk. So you're looking at reducing the risk, like future attacks. You want to prevent further complications in the patient, and the complications could lead to death, could lead to hospitalization. You want to make sure that there are no progressive decline in lung function and that it is rather getting better. So anything giving you less than 7.5, 0.75 or 0.8, then you know that you're having a problem with the patient. You could have patients having low oxygen levels. You want to look at that. Very important. And anything with the medication side effects. So if the patient is having hypoxia, then you realize that there's reduced risk. But you want to reduce that risk in this patient. So you want to look at all of this in the lung function, the medications, the side effects, the future attacks, the complications. You want to look at all of that. You want to reduce impairment. That is the frequency. I said it earlier on that the frequency could increase, the intensity also could increase. So you want to reduce the frequency and intensity of the symptoms that the patient could present, and we've just seen that in the former slide. And functional limitations in the patient. This is very important, and as we do that, you realize that we are on the right track in the treatment of the patient. Now, what are the strategies you want to look at for effective asthma management? First one is the patient healthcare provider partnership. Very important. The patient provider partner patient healthcare provider partnership, very, very important for us. Then good communications, then health literacy, and also asthma. So when you're looking at the healthcare, the patient healthcare provider, what are you looking at as a patient? You're making sure that you are there for your patient. You're making sure that you enable your patients to gain the knowledge that they want, the confidence, the skills to assume a major role in management of the asthma. Somebody will say you need to empower your patients. So when you empower your patients, then your patients can manage their condition well. So it is very important. And this is also an individualized care. We cannot treat all asthmatics the same. We want to treat them on an individual basis. The self-management and education also will reduce the asthma modality. So it is mortality in the patients and the morbidity. So it is very, very important that here you want to educate your patient and you want to improve that partnership. So the best thing you want to look at is empowering your patients so that they can take care of the asthma. Now you want to look at the good communication by healthcare providers. All you want to be doing is enhance patient adherence. Very important. Enhance their adherence to therapy and get feedback from them. As you get feedback from the patient, it means that then they understand what you're saying and they're going to do as you say they should do. So it is very important that we give them all the resources, especially when we have to use the devices. So when we empower them, we have good communication, get feedback from the patients on the devices they're going to use and how to use it, what to avoid, what medications not to take, and you realize that the patients also are happy and they would manage the asthma very properly. Asthma is not only for the patients, it is also for the healthcare worker. That is why you need to empower the patient. So making sure that you have empathy for them, you reassure them, you give them all the encouragement when they do well. Of course, you give them all the praise so that they know that their healthcare worker is with them and understands them and they are doing well. Then the last one is the health literacy and asthma. Now, most of the time, I said under diagnosis, under treatment was very common with asthma. And you realize here that we need to know and most of the time understand the basic health information, the services, so that we can give the appropriate decisions to our patient. Some of the patients don't understand the asthma condition, and some of them is because of the myths of asthma that they have around them. Sometimes some of them also is due to the cost. They do not understand it, so they will go for anything that is cheap or that is affordable to them, and then they will always go around looking for what they can get that would um, treat their condition. So the health literacy is very important, and all of that is to reduce the impact of impaired health and literacy in the patients. So you want to get any information that is important for them. If it's the action plan, you need to make them understand the asthma action plan, how to use it. They must be literate with it. They need to find out if they need their carer by them, for you to advise the carer to give them that information or to help with them. You want to make sure that you communicate in the language that they understand. If they don't understand the English, you want to make sure there's non-verbal communication. You want to make sure that the patients are very comfortable with the questions that you ask them. Anything that will make health literacy very important in this asthma is something you want to look at and make sure that the patient is comfortable and can be empowered in the treatment of the patient. So this is very, very important for us. This is a slide I like very much. And that looks at our treatment. If we understand this properly, treatment of asthma becomes very easy for us. Now, you need to assess your patient. You need to adjust it. Now, adjusting here, you're looking at either stepping down or stepping up and going to review your patient. So this is usually done most of the time to make sure that the patient is treated properly. It is not just set it, forget it, and not just on medications, but you need to assess your patient, adjust the medication, review, the symptoms of the patient. Now, when we say assess, what are we looking at? Of course, if the patient has been diagnosed as having asthma, then you are good to go. So you want to look at all the symptoms we talked about and some of the risk factors. What are the risk factors that the patient has? Which ones can we work on? I mean, that can be modified, of course, not the genetic ones. So the modified risk factors is what we want to look at and see what we can do. Now, does the patient have any comorbid condition? It's something we want to look at. What are the comorbid conditions? Some of them are obese. Some of them might have rhinitis. Some of them might have eczema. So what comorbid condition does the patient have that could be aggravating the asthma, or what you be using in treatment? Is the patient on any other treatment that also could be used for the asthma? You want to look at that. Very, very important when we're looking at that. So looking at the assessing the patient, you want to look at that. The inhaler technique and adherence to it. What is the inhalers are the patient using? Is the patient using any inhaler, or does he understand the technique? Do we just let them go when they come in? It's very important that we look at all of that to be able to tell the patient or the caregiver or the carer what are the preferences that the patient wants and the goal. If your patient keeps on telling you he wants tablets, you need to, it means that the education has not gone on well with that patient, and you need to look at it to be able to advise the patient properly. Now, when the patient is on treatment, we have a role to play there. And so the role of the pharmacist is that you're looking at the modifiable risk factors and the comorbidities that the patient has. What are the non-pharmacological strategies? What is it to be avoid? Now, you're not looking at treatment now, pharmacological treatment, you're looking at non-pharmacology. Now, for pharmacological treatment, we're going to go to that, to what the patient will take. Even for the non-pharmacological, what does he have to avoid? And even in looking at that, even for some of them pharmacological, we want to look at them avoiding NSAIDs, beta blockers. I mean, if they have to, we want to look at aspirin containing drugs in this patient. These are the ones they pick up all the time from the pharmacies when they have any pain. And you want to look at that, the FPAC, all of that. You want to look at all of this, the APCs that they pick up a lot. You want to look at all of that. Now, you want to look at the asthma medications, including the inhaled corticosteroids. What are they taking? Are they using it properly? Is the technique okay? You want to educate the patient. The skills training will be done tomorrow, and the action plan that will be done in the next lecture. So these helps you whether the patient is doing well or not, to know whether we want to increase, step up the medication that the patient is taking, that's the controllers, or step down. Okay, that is very important. So you want to step up either your inhaled corticosteroids in this patient, or you want to step it down. What other medications do you want to avoid this patient from taking? If it's an hypertensive patient, do you want to give all medications to this hypertensive patient, or you want to look at a medication that is likely to develop a cough in the patient, side effect of a cough in the patient? You want to look at that. In this patient, do you want to give him or her a beta blocker? You want to look at all of that in this patient because it could aggravate asthma. So we have a role to play there when we are adjusting therapy or advising. Now, review. Review again, you're looking at the symptoms. Is the patient becoming better? Are the conditions worsening? If it's worsening, then you have exacerbations. Okay, what is the lung function test when he's using the peak flow meter? You want to look at that. And then if there are some of the comorbidities that have been treated or are being treated, you want to also look at that. Of course, if it's obesity, you can always tell them that they should lose weight or encourage them on the kind of diets that they take also to help them. This is very, very important. So when we understand the assess, adjust, review, you realize that in treating the patient, it becomes very important as a pharmacist. Now we are going to be looking at these in the slides to come. So you need to understand them. So when I'm talking about LABA, all I'm talking about is the long-acting beta agonist, which is usually formoterol or salmeterol. SABA, the short-acting ones. The LAMA, which is the tiotropium. SAMA, which is usually the ipratropium. ICS, which is the inhaled corticosteroids. They could be beclomethasone, budesonide, fluticasone. You need to take note of that. LTRA, which is the leukotriene receptor antagonist, which presents as Montelukast. And Montelukast, we should also know the warning signs of it is that it can also give you neuropsychiatric effects. Okay, so if you have a child who has challenges with that, then you need to be careful also with your Montelukast reason for the patient. And OCS, which are usually the oral corticosteroids. We'll be seeing that in the next few slides. They understand it. Now, coming to this is the GINA guideline that is used in starting treatment in the patient. So for patients or adults and adolescents which are 12 years and above, I've talked about this, whereby you want to assess, you want to start treatment, and then you want to either here you are starting treatment, but with the rest, it might be reviewing treatment. And then you want to review. Okay, so you assess the patient, and then in assessing the patient afterwards, you want to start and then you want to review treatment in the patient. Very important that we look at all these to understand what the patients go through. Now, when you have this is usually based on evidence and consensus, okay? So this is evidence-based. Now, you realize that we were looking at initially the symptoms. Now, if you have a daily symptom, waking at night once a week or more, and have a low lung function or recent exacerbation, then it means that you need to start with track 1, where it is usually preferred that you give a medium dose ICS. In fact, let's start from step 1 because it makes it easier. So from step 1, if you have your symptoms less than 3 to 5, your symptoms presenting here, okay, and you have these symptoms presenting, and the patient has daily symptoms, waking up at night once a week or more, and low lung function or recent exacerbation, you usually start with this, the medium dose ICS formoterol, okay, and then or track 2, whereby you give your medium dose ICS, LABA and SABA. But most of the time with the step 1, you usually give your low dose ICS wherever the SABA is taken. Either you give your MAT treatment whereby you are giving ICS alone to the patient, or when you are giving your SABA, you are giving your SABA with your ICS corticosteroid. So you give your ICS SABA to a patient, or you give your ICS LABA to a patient. We need to look at that so you understand that, okay? So it is very important that you look at what you would give to your patient, and you will see that. That's why I talked about the LABA and I talked about the CI. If you are giving this, you usually give 2 inhalers to the patient, because you have your ICS, low dose ICS, which I talked about. It could be your fluticasone, it could be your glycinide that you're giving to the patient, and then, or you could give your glycinide to the patient, or you could give your what do you call it, flixonase to the patient. Okay, that is very flixotide to the patient. That is very important. Okay, so you want to look at that, or you would give your low dose ICS as needed, SABA, or you give your ICS SABA to the patient. These are very important in the step 1 and 2, because most of the time what happens is that you give this, which is the track 1 is usually preferred, but you would give this to a patient that has ICS and the LABA. So you would give this to a patient that comes as 1 inhaler, and that is like Symbicort to the patient. So you give as needed only low dose ICS LABA, which is formoterol, which is evidence-based in the patient. Or you give a track 2, whereby you give your ICS with your with your SABA to the patient. That's your salbutamol or any low dose inhaled corticosteroid to the patient. It is very important that we look at it. In this view, you have 2 inhalers, whilst here you have 1 inhaler. And I said it earlier on that we need to look at the patients and understand what they have. And cost becomes an effective, cost is it's important that we look at in this patient, because if a patient has to use 2 inhalers, inhaler technique is poor, it's better to teach this patient well to use 1 in that thing. Now, as you go up the ladder in step 3, now looking at the symptoms here, where most days the patient is waking up at night once a week or more, or has low function, then you want to make sure that you are increasing your ICS LABA in this patient. You might not give low dose, but you might also increase it and give low dose ICS formoterol as a maintenance and reliever. And most of the time, the maintenance and the reliever here is when you give maintenance and reliever is in the form of combined ICS, LABA, and then treatment in 1 inhaler. So that is like Symbicort that we have. It is very important that we get note of this. So when we say somebody is on MAT treatment, that is a maintenance and reliever, you are giving your ICS LABA as MAT treatment, and that is usually given from usually step 1, 2, and 3 to the patient. Okay, and it's fast acting for the patient because of the formoterol. Or you give track 2 to this patient, whereby you give both of it. Okay, now in this stage, in stage 4, whereby the patient always more on a weekly has a low function, recent exacerbation, you would give your medium-term ICS formoterol to this patient or give your ICS LABA to the patient. I hope you are getting what I'm talking about, because this is very important that we understand it. When the symptoms are less than 2 weeks, they just occur 3 to 5 days in a week, patient is fine, has a mild asthma, or when the symptoms increase, you realize that you increase in the step also. So you move from stepwise. That's why we say stepwise. You're giving the patient either stepwise, increasing it stepwise. So you're moving from one step to another step, and then you move up the ladder. But for us in community pharmacies, I want us to just look at step 1, 2, and 3, whereby we might use our mats but increase the doses in the patient. Step 4, you might be going to hospital, or step 5. And in step 5 or step 4, that is where we have our oral corticosteroids come in. So you realize that oral corticosteroid doesn't have any place in our treatment of asthma from step 1 and 2 and 3. And that is only when they get into hospital that the oral corticosteroids are given for short course use in them for the patients also who present with exacerbation. That is why I say we should take note that we don't dispense our salbutamol, oral salbutamol, to our patients who come to see us in the pharmacy. We are dealing more with the lower steps, and we should be doing more with the inhaled corticosteroids and our LABA, or inhaled corticosteroids and the SABA, which is the salbutamol, in 2 different canisters, which are given to the patient. Now, with the 2 different canisters, we should know how to counsel the patients also well. If they are using one, we should also know how to counsel the patients very well, and that is very important. So in this, we've just about what we've looked about, and this occurs also for the children. But I must say, for the children less than 6 years, you need to be careful of the kind of device that you use. You can only use the pressure meter dose inhalers for those, and you cannot use the other forms of like the other forms of devices that you want to use for the patient. So it is very important that we look at that and what kind of devices. That will be done in the next slide for us to know what we give to the patient, because you cannot use the Acuhalers and the rest for them. Now, looking at this is also for the adults. Now, looking at it for step 1, step 2, I talked about MAT, which we would use for the patient. So in step 1, your preferred controller and reliever, that is your Symbicort, which comes as MAT, which you use as your maintenance and reliever therapy in 1 canister for the patient. So using your ICS formoterol, which is in 1 canister, it is used as a reliever and is also used for maintenance in the patient, and that will decrease the or reduce the exacerbations compared to SABA alone. And SABA alone is just the salbutamol alone that is being used. We should also know that as we use salbutamol alone for the patients, that is what we talked about, the reliever over adherence of overuse of the salbutamol. It cannot be used alone. So your second line is either you are using that, or you are using your ICS SABA, which is also a reliever for your patient. So take note, please, that anytime you are giving medication to your patient, you are either giving your ICS formoterol, which is evidence-based, as giving that to your patient as in 1 canister, or you are giving 2 canisters to your patient, where you would give your salbutamol, but you have to add your ICS to it. And your ICS is just the inhaled corticosteroid that we've talked about earlier on, and most of the time this would be used in 2 canisters. So if the patient has to be on this 2, then it means your counseling has to be appropriate for this patient to be able to have a good controllers use, or controller use, which is usually an alternative for the patient. So if you want to give your ICS with SABA as an alternative, you want to give your ICS low dose maintenance ICS here, of course, with the SABA, and then you also want to give your low dose maintenance here, where you are introducing your ICS LABA here, and that is where you might be using it for MAT here, and you need to take note of that in the patient. So you either use, which is preferred, your ICS formoterol for this patient that would reduce the risk of exacerbations, or you want to use both your controller and the reliever for the patient, and that is what we should take note of. Now, since 2019, GINA came up with a fundamental change in asthma management. and it says that treatment of asthma with short-acting bronchodilators alone is no longer recommended for adults and adolescents. And that's how sometimes we find ourselves wanting in the pharmacies, because we only give our patients their salbutamol and we have issues with them having exacerbations. So why not treat your patients with inhaled short-acting beta agonists alone? You will not treat your patients with this alone because you are treating the symptom but not the disease. And I realized earlier on that when we looked at the pathophysiology, we realized that the hallmark of asthma here is inflammation. And most of the time, that is it. I mean, you're looking at the respiratory symptoms and you're also looking at the airflow obstruction in the patient. And that is usually caused by inflammation. And that is why you have the bronchoconstriction coming up there. And then you have lots of mucus being produced. And then you see it also with the constriction of the bronchioles, and definitely leads to thickened airway, and also leads to also the mucosa also, or the mucus, or the muscle also being constricted. So you see it present in the patients like that. So SABA treats the symptoms but not the disease. And we know here that in asthma, we are dealing more with inflammation, and that is very, very important for us. That is why treatment must be looking at inflammation. If you are just looking at the symptoms, you will not be going to the bottom of your treatment, and that becomes an issue because the patients don't understand and feel that if they take their salbutamol, they're okay and good to go. Patients or people with apparently mild asthma can have severe or fatal exacerbation. These are lots of surveys to prove the evidence-based medicine of what we are doing and what is being done. Up to 27% asthma deaths are in patients with occasional symptoms, okay? And that was done in 2008 by Bergstrom. Exacerbation triggers are unpredictable because you could be treating your patient, but if they do not identify the trigger factors, or they go into a place whereby they have the allergens, or they get excited, or they walk into a factory whereby you have dust particles, you have a viral infection, any of those, you realize that that could trigger the patient's condition. Even 4 to 5 lifetime oral corticosteroids like our prednisolone and dexamethasone that we give all the time increases the cumulative risk of adverse effects, including osteoporosis, diabetes. Also, you will find out that as you abuse your steroids, you would also be increasing your danger or of also getting diabetes. Okay, so diabetes also a non-communicable disease that is also prevalent in our country, and as you give your oral corticosteroids to your patients, you are worsening your osteoporosis in the elderly patients and also increasing risk of diabetes in the patient. Cataract, heart failure, pneumonia. And that is very important that we look at because of the oral corticosteroid uses that we always have. And we saw that earlier on in the slides. Regular use of SABA, we've talked about that, the salbutamol. Sometimes the patient could be using it for 1 to 2 weeks, and that's all they keep on taking. And so you realize that that will lead to your hyper-responsiveness in the patient, and reduce bronchodilator effect, increase allergic response, increase eosinophils also in the patient. So that could lead also to encouraging overuse of your SABA. And overuse of SABA is been associated with increased exacerbations and increased mortality in the patient. And we must take note of this because this is very true and it happens and it is evidence-based. Starting treatment with SABA trains the patient to regard it as the primary asthma treatment. So most of the time when they are not used to using the other devices, okay, then they get used to using the pressure metered dose inhalers first, then they can aggravate to the others. So in this case, sometimes that is when we want to use the two for them, using your ICS and using your steroid. But it's good to train the patients how to use your inhalers, and we could learn all of that tomorrow so that we are well versed also in treating our patients to let them know the right treatment. Poor adherence with the inhaled corticosteroids is also inevitable. And so sometimes we introduce the inhaled corticosteroid. But I said earlier on, most of the patients, when they're fine, they stop taking their treatment. Even though they should continue on the ICS, they stop taking treatment and they wait till it is triggered again. And then when it increases in intensity, they end up in the emergency ward. There's also strong evidence for a more effective and safer alternative than SABA alone. And I've said it earlier on, or your ICS with the SABA, or you want to use your needed ICS formoterol for the patient. So are you either using your ICS plus your SABA, or you want to use, which is preferably your ICS formoterol for the patient. Now, oral bronchodilators are not recommended in these patients. We said it earlier on. So your salbutamol tablets and the syrup, oral theophylline, that are not recommended in the patients because you will not be treating your asthma. You are just dealing with some symptoms in the patient. That has a slow onset of action. There's less effect in symptom relief than inhaled bronchodilators. There's more adverse effects in the oral medications. That's why you want to look at it. And that's why I said earlier on, the more you use the oral corticosteroids, you are aggravating or also increasing other disease conditions in the patient, which you might not even be aware of until you notice it later in life. So with your inhaled choice and environmental considerations, that will be done in the next presentation. It is very important that these are used because they reduce the risk of asthma exacerbations and death. But limited availability and access in low middle countries and income countries is a problem for us. We have them, they might be on insurance, but they are not affordable for the patients, or they might not be, the prices are above the insurance prices, so we cannot be reimbursed for using them. So that's why sometimes, even though it's on insurance, it might not be accessible for the patients to use. And they use all sorts of things that would even worsen the condition of the asthma, and even some of the smell or the scent of some of them might trigger even the asthma in the patients. So many inhaler types are available. You could see them here. You could see the acute inhalers. You could see them, the pressure meter dose. You could see the DPIs also here. They're all used here, and we'll see them in the next slide. Some inhalers are not suitable for some patients, and you need to note. Like I said, the DPIs are not suitable for children less than 5 years because they will not be able to inhale and exhale or actuate the use of the inhalers. So you need to be careful of that when you're using. And also with the pressure meter dose inhalers, you can use your spacers. But if you're using your DPIs, you cannot use your spacer for that. So you need to look at that. So it is difficult for patients also with arthritis and weak muscles. And then you need to make sure that the patient does not use more than one inhaler in about 3 months. Most of the time, they use the inhaler, gets finished, they go for another one, gets finished, they want to go for more. Either they are not using the inhalers properly, or they are going to have, if they are using more than 12 canisters in a year, that is going to increase toxicity in the patient and death. So your incorrect technique also, more symptoms that we will do today and tomorrow, would also help in improving also treatment in the patient. It is very, very important that we know that the propellants in current pressure meter dose inhaler have 25 times global warming potential compared with the dry powder inhalers. And so we take note of that. And the choice of the inhaler is very, very important for the patient. You need to speak to the patient, and we talked about that when we're looking at communicating with our patient, and that will tell you as you talk to your patient the right medication you want to use for your patient, the right device you want to use for the patient. And that is also very, very important in communicating with the patient. So it is very important that we look at that when communicating with our patient and having a patient healthcare partnership in the patient. So inhaler choice and environmental conditions, I think I wouldn't want to talk more about this because we're going to look at that in the next slide. So you want to note that and use your inhaler technique frequently. So in summary, the 4 essential components of asthma management are patient education, control of asthma triggers, know your triggers, know your triggers, know your trigger factors and avoid them. Okay, monitoring in changes in the lung function test. If you're using the peak flow meter, you want to look at that. You want to have an asthma action plan, and also you want to look at pharmacological therapy in the patient and non-pharmacological. Very important. Asthma is not curable, but it is controllable, and we must take note of that. Using 3 or more reliever inhalers a year indicates a person is at risk of a severe asthma exacerbation, while the use of 12 or more is an indication of someone who is at risk of asthma-related death. So in conclusion, asthma is a common chronic, complex inflammatory disorder of the airway that cannot be cured but managed. The good news is that the person with asthma can have a life expectancy as long as someone without asthma. So there's really hope for our patients if we empower them and we treat our patients adequately. The common symptoms of asthma are breathlessness, wheezing in the patient, cough, and chest pain. And the key stone of pharmacological therapy is patient with asthma is using our effective anti-inflammatory drugs. It is the inhaled corticosteroids, effective anti-inflammatory drugs, and we are looking at inhaled corticosteroids. The inhaler technique is crucial to ensure that drug delivery is effective. The use of beta agonists alone is associated with serious adverse effects. Thank you very much.
Thank you very much, Auntie Amma, for that insightful presentation. It is a manifestation of your deep knowledge and understanding in asthma management. Once again, thank you, and we are grateful for your presentation. Before I introduce the next facilitator, I would want you to take note that you can send your questions to us through our question box, and it will be answered by our facilitators. And I think Auntie Amma has even introduced the next facilitator, but let me officially introduce Professor Victor Wuto. He's a certified respiratory educator and also a fellow of the College of Pharmacists. He's a practicing pharmacist and has a special interest in community pharmacy. Ladies and gentlemen, may I have the honor of introducing to you Prof. Victor Wuto. Thank you, Prof. You are welcome. Hello, Prof. Wuto.
Prof, please, you are not audible.
Please, we still can't hear you.
See. Yeah, I can hear you. Okay, are we good to go?
Yes, please. We are good to go.
I think we needed a short break before we. That's just fine. Okay.
I think so too.
All right.
Welcome.
Ladies and gentlemen, in a recent study of asthmatics, a large population size, 93% of asthmatics believed that their asthma was under control. However, based on the guidelines, only 9 out of 10 of them did not have their asthma under control. 44% of asthmatics avoid exercises because of the fear of exacerbation or attack. 33% of asthmatics miss school, they miss work, or other social events. Ladies and gentlemen, this is the condition we are dealing with, and we as pharmacists have a major role to play in helping those patients, helping our economies, and helping our country and our profession. I will be making a presentation today on the role of pharmacists in asthma management. And let's go there. The outline of my presentation, I'll be looking at asthma, the goals of management, the role of pharmacists, and then we'll summarize it and have some time to discuss some of the issues of interest to us. I wouldn't waste time on this part of the presentation because the previous presenter did a very good job on that, and thank you very much, Dr. Nkansa, for doing most of that. That was brilliant. So asthma is just a chronic lung disease, which is characterized by all the things she said about that. But we'll get to a point where we come to realize that the disease itself has an underlying inflammatory condition, which has to be taken care of. Otherwise, we'll just be beating around the bush and not doing a lot for our patients. Now, the question you ask yourself, I would just take a look at this picture. When you have a normal airway, we have asthmatic airway, we have an attack. That is what happens under those conditions. And this is something we will have to present or prevent as much as possible. Now, I'll give you a brief background information on that. Asthma is one of the most common chronic diseases, and it poses a substantial socio-economic burden on both patients, the caregivers, and the country. And quite apart from the fact that it's a burden on the patients and their caregivers, being their parents or their healthcare professionals and stuff like that, it also has an impact on the economy of the country. Assuming that most of asthmatic patients have their asthma under control, a lot of money that goes into paying for their medication through the National Health Insurance would have been saved towards other medical conditions. So asthma has a major impact on not just the patients or their caregivers or their families, but also on the economy of the country. Asthma affects people of all ages, children, anyone. And it negatively impacts schooling and activities. Asthmatic kids don't want to engage in other activities because of the fear of exacerbation or attack. Now, in addition to that, poorly controlled asthma is associated with significant increase in missed schools and work days for children and caregivers. Ladies and gentlemen, despite the availability of effective therapies, the management of asthma remains a challenge as it is dependent on the behavior of patients, healthcare professionals, and the disease severity. So in that equation, healthcare professionals have a major role to play in that, managing the asthma in patients. Now let's go on to who the pharmacists are and what is our role. Now, pharmacists are the most easily accessible healthcare professionals. You hear that over and over and over in virtually every presentation. Now, so the question is asking, if you are the most and easily accessible healthcare professional, what are you bringing to the table in terms of asthma management? In most situations, pharmacists are the entry and the exit point for most patients. So most of them will come to you and speak to you in the community as the entry point with their healthcare problems. After going through all their problems and the counseling and everything, you may refer them to see a physician. After seeing the physician, most of them will come back to the pharmacist. So you play a vital role at the entry and the exit of the healthcare system for most patients. And being that readily available and easily accessible healthcare professional, you stand a very important chance of helping manage chronic medical conditions by educating people, making the referrals, conducting all the screenings, making sure the right patients get the right medication at the right dose at the right time. Now, as pharmacists interact with patients on ongoing basis, which is something that happens on daily basis, you can play an active role in asthma management based on your knowledge and expertise in medication management. As an integral part of the primary healthcare team, a pharmacist has an important role to play. We can provide long-term follow-up care to manage chronic diseases, and we are uniquely positioned to improve outcomes in asthma patients, given our clinical knowledge, our understanding of the condition, and then what we bring to the table. A comprehensive review, including about 25 studies, show that pharmacist-led interventions improve asthma outcomes, such as the asthma severity and the health-related quality of life. And it also reduces healthcare utilization in community pharmacy settings. And by doing that, we improve asthma symptoms and reduce healthcare utilization in ambulatory clinics. Proactive and continual pharmacist engagement with asthma patients, physicians, nurses, and specialists achieve optimal asthma outcomes. Now, as a pharmacist who is trying to help an asthmatic patient, what are your goals? Now, it's always expected that as a healthcare professional who has an asthmatic patient you're working with, your goals for asthma management should be good asthma control. You want to control the symptoms. You want to minimize asthma-related mortality and morbidity. You want to minimize asthma exacerbations. You want to minimize persistent airway obstruction and limitation. And you want to identify the patient's goals for asthma and treatment. That's a very important one. Gone are the days when the pharmacist tells the patient, do this, do that, do this, do that. In this era, as a pharmacist, you have to work with the patient to make sure that you are both on the same page. Because if you don't do that and you just impose your wishes on the patient may not take your medication. And if they don't take the medication, you would not have achieved anything. So you have to work with the patient, identify what their goals are, what is achievable, and what could be achieved together as a team, together with the patient and your other healthcare professionals. Now, when you are helping an asthmatic patient, there are a few things you have to take into consideration. You have to aim for 0 for all your patients. That is an ideal situation, but we know it is not achievable. But you cannot start from the bottom and hoping to get higher. You start from the top, and even if you don't achieve that and you get closer, you'd have done a lot of good for your patients and yourself. You want to aim for 0 symptoms. You want to aim for 0 nighttime awakenings. You want to aim for 0 time lost from school, work, or play. You want to aim for 0 exercise limitations. And you also aim for 0 emergency room visitations. Then you ask yourself a major question. Why do we have poor asthma control? Where 9 out of 10 people do not have their asthma under control. Why? Now, a few answers pop up quickly. Now, your patient may not be using the right asthma medication to treat their asthma. If you're not using the right medication, we don't expect the right treatment. We don't expect that your asthma will be under control. You are not using your inhalers properly, which is a major concern. And it's something you even find with, so when I have students on experiential training, that's one thing I try to give them. I have a patient, an asthmatic patient. I want you to go over the techniques. They miss it a lot. There's several important points they miss along the line. So not using inhalers properly is a major problem. The techniques are not right, even amongst healthcare professionals. Not using your controller medication regularly. A lot of patients don't believe that their controller medications are working because they don't see the results immediately. When they use their salbutamol, they expect it straight away. They see it, they start breathing well. But when they have to be on the controller medication, they are of the view that I'm not seeing anything there. Even when I inhale it, I can't even taste anything. So they don't even believe that it's doing any job for them. It is your responsibility as a pharmacist to educate them, guide them, give them all the information they need about controller medication. Being exposed to triggers causing breathing problems. Now, if you are treating your asthma and it's work related, every day you go back to the same job under the same conditions, you may not be getting the results you want because you are exposing yourself to the triggers day in and day out. I know that sometimes it's tough to do, but I believe strongly that if you find yourself under such conditions, you should be able to speak to your employers. They may have to find another job for you, change your position, change somewhere else for you to find out, so that you can try have a healthy, control your asthma and also continue with your work. Over-reliance on the reliever rescue medication is a major problem. Dr. Nkansa was talking about it. If you're using more than 2 of your inhalers in a year, we have a problem right there. But pharmacists will continue dispensing metered dose inhalers, salbutamol, Ventolin to their patients, so long as they come to buy, they sell them. I can understand. Pharmacy practice, especially in the community, is a business, but it's also a healthcare. So we have to balance it out. You're not only selling drugs there, you're looking at the health of people. If you are selling salbutamol inhaler to your patient once a month, ultimately you're not helping the patient. You may be making money, but sooner than later, if you lose that patient, where is the money going to come from? But if you maintain them on the right medication, you have, it's sad to say, but you have somebody who will be visiting you, will respect you, and seek your knowledge in every situation they find themselves with regards to their health. You're not following your asthma action plan. Those are some of the reasons why we have poor asthma control. Now, there are some factors that influence clinical outcomes in asthma. Let's take a look at here. Asthma control can be achieved in most patients. That's the fact. If we have all the conditions right, if the diagnosis is right, the medication is right, the doses are right, your patients adhere to the directive, asthma control is achievable in most patients. Several factors influence asthma control. They are disease related, so the asthma type, the comorbidities, and the triggers. They are patient related. That's where the socio-demographic factors, adherence to medication, perceptions, knowledge, and behaviors, and the healthcare related. What the healthcare professionals, you misdiagnose the condition, your knowledge of current guidelines is very weak and very low, your attitude towards the guidelines, and the implementation of the guidelines. We have healthcare professionals who will give medication to patients without referring to the guidelines. Now, if you are doing your own thing, you don't respect any guidelines, the question then arises, what kind of pharmacy are you practicing? All right. Now, so I've talked about the disease-related conditions, the patient-related conditions, and then we'll come to the healthcare-related problems. Now, with the disease-related conditions, the previous presenter touched on the types of asthma, the comorbidities, and that. Now, let's look at the patient-related factors. In the patient-related factors, the patient's perception. You speak to patients, they'll tell you, I'm not taking my steroid. Why? Because I hear that when I give steroid to my child, it's going to affect his height, he's not going to grow tall. Now, I always say this. Have you seen a short person die just because they are short? No, it doesn't happen. But somebody who doesn't have her asthma under control could die. On the scale of balance of the good and the side, the benefit, this thing, will you rather kill your child or give them a medication that may reduce their height? You could be short and then still be the president of a country. You could be short. You could be the CEO of a big company. But if you don't give them the medication, they die. You'd have lost them. So that is something I discussed with them. And every time I bring it up, they laugh, especially when you're talking to Ghanaians. But that is fine. I like to joke about some of those things. Lack of adherence to medications. Inaccurate inhaler technique. Occupational triggers. Sedentary lifestyle. You sit at your desk every day. You go to work 8 hours just sitting at the table. You don't even get up to go take a break. You don't walk around. It doesn't help in any way. We have low socioeconomic status and lack of education. Now, one thing I want you to understand is that literacy or education is different from health literacy. Now, we have people who are highly educated, but their health literacy rate is very, very low. And I'll give you a typical example. I had a professor at the university who is on this Flomax, that's the tamsulosin for his prostate. Now, the direction for prostate is you take one tablet daily at with the same meal every day. Now, his understanding of the same meal every day was to force the wife to cook the same kind of food for him every day. But that statement that the same meal every day is you just have to be consistent. If you're taking it in the morning, that's your breakfast. If you're taking a supper, it's your supper. So health literacy is very different from being educated or being highly literate. So you have to take that as a consideration. And the presence of comorbidities. So these are some of the things you have to look at carefully when you are dealing with a patient. You have to make sure that you cover all their potential problems which are related to the patient whilst you do your job as a pharmacist. Now let me delve into the role of pharmacists in asthma management. I have 6 points to consider here. Your role in screening and identification of patients at risk of developing asthma and exacerbation. If you have a patient who is only using a salbutamol, day in and day out, that's all they take. And every now and then they take Asthmadrin. Every now and then you go and take some prednisone or they take antibiotics. Ladies and gentlemen, you have the right as a pharmacist. It's your responsibility actually to notify this patient that, look, what you are doing is not right for yourself. And you stand a chance of developing an attack or there should be an exacerbation. You could even die. Recommend individualized treatment. It's not a one size fits all. Now you start some treatment for some patient, it doesn't work. You have to make judgment call there. You have to make changes to because like I said, one size doesn't fit all. You may have to change the dose, increase the dose, and that kind of thing. You want to educate your patients about the disease, the management strategies, and the inhaler techniques. One of your roles is to create awareness among your patients regarding the trigger factors and provide strategies to identify and avoid them. You want to encourage medication adherence, very important. It's a major factor. And we want to be able to refer patients to specialists if need be. If it's beyond your capability, it's beyond something you can do, just refer the patient. And when referring the patient, it's advisable to give them a note or something so that when they get to the specialist, they know that this was a referral from the community pharmacist or the pharmacist. We hardly do that. So at the end of the day, nobody sees the role we are playing and what we are doing as pharmacists. But when you send a referral note there, keep a copy for yourself, keep a copy for the patient. You can follow up with the patient in 48 hours, 72 hours to find out how did your referral go? When you met the physician, the specialist, how did it go? Now, by contacting the patient to find out how they are doing, you stand a better chance of the patient coming back to your pharmacy for you to continue with the treatment and the guidance and advice. Now, how do you monitor to share that the patient's asthma is under control? There are a few guidelines, there are a few assessments that you can do. But there's one that I readily use in my practice. Very simple, basic, 4 questions. You get your answer quickly. Now, it's a GINA assessment of asthma symptoms. You ask them daytime, night symptoms. In the past 4 weeks, has the asthmatic patient, have you had daytime asthma symptoms more than twice a week? Yes or no? Nighttime, reliever use, activity limitations, yes or no? If all the answers are no, the asthma is well under control. If they are telling that 1 or 2 of those conditions are yes, we have a partially controlled asthma. And if 3 or 4 of them are yes, asthma is not under control. And more often than not, when you see patients that complete the form, 1 or 2 is there. 1 or 2 of the factors are there, which tells you that the asthma is not under control. Now, once you complete this form for your patient, every time they visit, they give you that information. It's a good indication for you to see that the patient's medications are actually working or they're not. All right. So this is a quick assessment that you can use in your community practice or in your pharmacy or any practice you find yourself. It's an easy thing. You ask the question, you take yes, no, yes, no, yes, yes. That gives you a straight away answer. You have the date there, you keep it. The next time you come, you do the same thing. That gives you a fairly straight away direction as to whether the asthma is being controlled or it's not under control. And once you have that information, Then you can advise them appropriately, find out why that is happening and what could be done about it. Now, there's also another thing that I try to use a lot. It's something that I mean, it's in my practice. I try to find out how many inhalers they use. That's the asthma slide rule. So if you have a patient who uses 4 puffs a day, all right. Now, if you look at, if they use for, look at so we have number of SAB inhalers per year, puffs of SABA per year, that kind of thing, all right. So if you look at the bottom, it says puffs of SABA used per day. So if your patient uses 3 puffs a day, that puts them at 5 meter dose inhalers in a year. That is a disaster. All you are looking for is that they don't want to go beyond 2 of them in a year. So if they are using 3 puffs a day, then the indication is that they are probably using about 5. We have patients who are using about 4 Ventolin puffs a day. They use 2 in the morning, 2 in the evening, 2 morning, 2 afternoon, 2 evening. Some even use 6. Now, if somebody is using about 4 of those puffs a day of salbutamol, you're looking at about 7 or 8 canisters a year. That is a recipe for disaster. The patient is going down. And as a pharmacist, you have a responsibility at that point in time to sit the patient down. You got to talk about their treatment. It's not working. Something has to change. It takes you education. Educate them. Let them know the pathophysiology, what is happening. By using the short-acting beta agonist, you are getting the relief immediately. But technically speaking, you are not taking care of the inflammation, which is the backbone of the medical condition. By taking the inhaler every day, you are it's like you have a sore, right? You are not treating the sore. You're just trying to put a little bit of a soothing this thing on it. You have inflammation. All you do is you take 1 tablet of Advil every morning and you're able to get out there. You ain't treating the inflammation. All you are doing is taking care of the pain there, a little bit there. It becomes a major problem along the line. By the time such an asthmatic patient who is using about 5 canisters a year ends up at the hospital in an emergency, it's a big problem. You need to explain all that to them. Without education and with the kind of perceptions they have, some don't even believe in that. If you're not doing your job right as a pharmacist, the patient are not going to get the results they need to manage their medical condition. Now, let's look at some educations that are things that we need to touch on. Now, general health literacy is essential for successful asthma. I talk about that. The health literacy is different from just being educated or that. Providing tailored education can overcome low literacy barriers and improve asthma management. So you need to speak to them. You don't assume that the person who is coming to you with asthma or somebody who is picking up medication for their child holds a doctorate degree in something, so he must know about it. It's a mistake we make in our practice. It should never be the case. If you ask that person who is standing in front of you, who holds a PhD in something, to show you how to use an inhaler, most of them will get it wrong. So don't make assumptions. Make sure you cover your basics. The right thing has to be done for each patient. Now, another thing that I'm going to talk about is the asthma action plan. You know, pharmacists are not doing well when it comes to asthma action plan. I'll tell you something about it. Every asthmatic patient should have an asthma action plan. If you are not doing that for your asthma patients, you are not doing your job as a pharmacist, and you are not helping your patient. Now, the question is, what is an asthma action plan? It's a written action. It's like a contract between you, the pharmacist, the patient, and their physician. On the asthma action plan, the 3 of you have a contract. You have a responsibility. The patient has a responsibility. The physician has a responsibility. So you are signing a contract. Asthma action plans provide information on medications and their dosage, how to recognize symptoms worsening, and the steps to take in case something like that is happening. I did some work recently in Accra, selected pharmacists, and I was interviewing about 200 patients. So I was looking at the knowledge level of caregivers whose children have asthma between the age of 5 to about 18. And out of that, less than 20% of the children, I think technically speaking, most of them, about 19.4%, I think, had asthma action plan. And unfortunately, all these asthma action plans came from the specialists, not even the general practitioners. There was none from a pharmacist, zero from pharmacists, zero from general practitioners. The 19.4% came solely from specialists. What kind of pharmacy are we practicing? But we sell the medication to them. We don't even counsel them. We just sell it. They come to buy asthma medication. You just sell it to them. We are not providing them with asthma action plan for them to know that when asthma is getting out of control, when this is happening to me, this is what I have to do. This is what I have to do. We're not doing that. I mean, from that study, which has been accepted for publication, it should be out very soon. I'm hoping to have a chat with the medical society as well. This I'll present it to them. Now, if the general physicians are not doing that and the pharmacists are not doing that, it's only the specialists. And even then, to be very honest with you, when I look at some of the asthma action plans that they have, better than nothing, but it is not the ideal thing, but it's better than nothing. Ladies and gentlemen, we are not doing our jobs as pharmacists. We are not helping our patients. If our patients don't have asthma action plans, we are not doing the right thing. Now, I'll give you a prototype of asthma action plan. You have the green zone, the yellow zone, and the red zone. It's just like your traffic light, right? So when you're in the green zone, you are all clear. There's no asthma symptoms, and your peak flow meter is between 80 to 80% of your maximum. So at that point in time, everything is all right for you to go. In the yellow zone, some asthma symptoms are showing up, and your peak flow meter gives you between 50 to 80%. At that point, you know what to do. The asthma action plan will tell you that. When you are in the red zone, you are less than 50% of your best. Something has to happen immediately. This is a typical asthma action plan. So you have a contract with the patient. When you're in the green zone, everything is working fine. When you're in the yellow zone, probably have to increase the dose of your ICS. You have to increase the dose of something. You have to do something. It's all there, written clearly. When you're in the red zone, then you also know what to do. Ladies and gentlemen, I think that we should incorporate asthma action plan in our practice. By doing that, we'll be helping our patients. By doing that, we'll be helping our profession. And by doing that, we'll be helping the country. Inhaler devices and asthma management. Inhaler devices are the cornerstone of asthma therapy because it allows the delivery of your medication directly to the intended site of action. And because it goes straight into your lungs, it minimizes the side effects. And you require a lower dose of the drug to give you the effect you want. That is something a lot of people don't understand, don't get right. The reason why the inhaled medications are best for asthmatic patients and COPD patients is that you are using a very low dose of the medication. And because it goes straight into your lungs, you minimize the side effects. And then your drug goes straight to where it's needed. And that is the reason why some of those medications, oral medications we take, actually don't do us a lot of good because the side effects are just too much. It goes into the whole system, it gets absorbed into the system, all the side effects are prominent and has major effects on you. So the main classes of asthma inhalers, we have the nebulizers, we have the metered dose inhalers, the pressurized metered dose inhalers, we have the breath actuated, we have the DPIs and the soft mist. And I mean, yeah, I'm not going to delve into that. Now, asthma controls depends not only on the pharmacological agent, but also on the inhaler that was used to deliver the medication. The previous presenter mentioned that, which is very important. It's not just giving the patient the medication, but the right medication has to be given for the right age in the right dose. So it's essential that the right inhaler is given to the right patient, taking into consideration the needs, the abilities, and the preferences of each patient. Inhaler mishandling is common in real life, even amongst healthcare professionals. You have to keep training, you have to keep assessing, and you correct the inhaler techniques. Pharmacists play a crucial role in the initial training of patients on correct inhaler technique and ensuring that this is maintained over the long term. Now, you have patients who will come there, they pick initially their first time, you train them how to use the technique, the right techniques. Now, when they come back and you ask them, oh, are you okay with the technique? This 99.9% of them will say, yes, I'm all right. But when you give them the inhaler, this thing to show you, only a small percentage will get it right, which means that there is no need for you to keep asking that question. Do you know how to use it? You just want to ask them to show you how to use it. So you train them, you assess it, you correct the technique every time you have a patient there. And please do not rely on written or verbal instructions only. You have the hands-on is important so they know how to use them. And you want to employ a step-by-step demonstration of inhaler techniques with periodic assessment. Very important. If you ask the patient, oh, can you use the inhaler? They will say yes. I mean, look, nobody wants to look stupid in your face. They don't want to look stupid, that they don't know what you are doing. So if you ask them that yes and no, close answer, you get a close question, you get a close answer. Open up your question. Could you please show me how to use this inhaler? They will try to show you how to use it. They will get it wrong, and then you get them back on track. Very important. You want to assess the patient's technique and rectify it as much as possible. I have a video that I wanted to play for you, but I'm not sure it's coming up there. Can my presenter do that for me? Can you get the video up? If it's not possible, we'll just move on. And I also don't want you to just written documents, this yes, no kind of thing. I want you to utilize audiovisual aids. Bring up the thing on a computer, show it to them, let them see how it is done. Select very important and proper techniques. Get them there so that when you just go there, you don't waste your time now going to look for something. Have them as part of your training so that you just show it to them and they see what is happening there. Audiovisual works for a lot of people. It's not everybody who learns by reading. Some people learn best by watching. So you have to take care of those people as well. The next thing I'm going to talk about is medication adherence. Medication adherence is a multi-phase process. The initiation of the prescribed therapy, implementation of the therapy as prescribed, and subsequent or persistence of the treatment regimen. You want to make sure that when a physician prescribes the medication for the patient, you go over the medication, explain to them what the drug is supposed to do. So that's the initial stage of it. And then you have to implement it. You follow up with the patient, find out how they are doing. Are they having any challenges? Are there any side effects? Encourage them to continue doing the right thing. Adherence to therapy remains suboptimal in many chronic diseases, not just asthma. But if you are going to be an expert in this area, then you have a responsibility to make sure that your patients adhere to treatment. They will have questions. I don't believe this drug works. I hear that when you take this drug, this thing happens to you. I hear this, I hear that. You have a responsibility as a pharmacist to give them the right information, to give them all the necessary information they require. Every drug has side effects. Bottom line, there's nothing you can do about that. That's the fact of the matter. For some people, even water has side effects when they drink water. So you need to give them all the information they need to help them make that call, to help them make that judgment between the two of you. Many patients tend to overestimate the risk related to ICS. They will tell you so many things about the steroid. It does this to me, it do this to me, it do to me kind of thing. Look, it takes just time for you to sit down with them, explain to them what the data is, what the statistics are, the importance of maintaining the asthma under control. They are pregnant, they are planning on becoming pregnant, they stop using their inhaled corticosteroids. There are corticosteroids you can use in pregnancy. It is up to you as a pharmacist to explain all those things to them. If they don't have their asthma under control, they get pregnant, chances of ectopic pregnancy, chances of losing the baby, chances of having other problems are high. compared with having the asthma under control. You need to explain all those things to them. They don't want to use the ICS because the onset of action is not as quick as their short-acting beta agonists that they see instantly. We still have a lot of people using asthma in Ghana. We still have a lot of people just taking the prednisone tablets, taking all those medications. It's a very difficult situation we find ourselves because some of them will tell you, I don't have money to buy the medication. I don't have the money to buy. That's the only one that gives me relief. That is where you have to come in, explain to them, taking this medication, taking your asthma, and taking your oral short-acting or those medications that affect your causes bronchodilation. Long term, it's not going to help you. You have to talk to your patients about all these things. Medication adherence, it's very, very important in asthma management because a lot of your patients will refuse to use inhaled corticosteroids because of the myths, because of the stories they have heard about that. You have the responsibility to speak to them about all these things. Effective communication between the patient and the pharmacist can help achieve adherence to maintenance of the ICS medication and prevent adverse effects and mortality associated with the overuse of bronchodilators in the absence of ICS. You need to involve your patient in the decision making. You don't just give them the medication and let them go. You're not doing your job as a pharmacist. Medication adherence is very important in asthma management. And you, being the first point of call and the last point of call in the healthcare system, have a responsibility to make sure that your patient knows what they are taking it for, the dose they are taking, and what to do when there are problems. Another important aspect of your job, of your role as a pharmacist, is to identify trigger factors. You have to work with your patient to identify the trigger factors, and you have to find effective ways to manage them. Some of the trigger factors, you're looking at tobacco, smoke, pets, mold, infections, bad weather, physical exercise, fragrances, and stuff like that. You need to identify them. If your patient trigger factor is the use of fragrance and they like nice perfumes. I mean, what if you are an asthmatic and nice perfumes causes a problem for you and you still want to use them, then we have a problem. We need to figure out something to do for you. It's your responsibility as a pharmacist to do that. In the next slide, I'm just showing a picture of some of those things, and I'm not going to worry about it because Dr. Nkansa touched on those. Now, let's look at some general education. You need to educate your asthmatic patient who still smoke. You need to let them know about what is going to happen in that case, how the smoke may reduce the effectiveness of some of their medication, like the ICS. You have to provide your patients with detailed explanation of how asthma medications work. Environmental interventions that could improve their asthma control. You want to ensure that your patients are aware of the treatment options. If you're not doing all this for your patients, then we have a problem. They need to know what is available to them. It's not only what is in your pharmacy or what you have. They need to know what is available. And cost becomes important at that point in time. If you have drug A, ICS, which costs less than 100 cedis, the patient doesn't have the money, but there's another ICS there which costs about 60 cedis. Why would you want to force the patient to buy it? They kind of buy it, and so they go without any treatment. Give them all the options. It's up to them to decide what they want to use based on their financial capabilities and what is going to help them. You need to personalize treatment, like I said. Asthma is heterogeneous. So one size does not fit all the situations. So you need to personalize treatment for the patient. The patient's, what is the outcome the patient wants? You need to work with them. The asthma action plan is an individual contract. Despite the availability of all these treatment options, about 50% of asthmatics are not under control. That is not right. And also, quite apart from the pharmacological, we also have the non-pharmacological interventions that we can employ. regular exercise, consuming a healthy diet, cessation of smoking, avoiding your indoor allergens, treatment of modifiable risk factors and comorbidities such as obesity, anxiety, and all those diabetes and all those things. All those things, when they are taken care of holistically, you stand a better chance of having the asthma under control. So don't rely solely on pharmacological intervention. You also have to look at the non-pharmacological interventions. A patient who is very obese may not have the asthma under control, even though they may be using the right dosage. They may end up using more doses because higher doses, which will precipitate more side effects because they need more. But if they can reduce their weight a little bit along the way, a little bit of exercise here and there, you stand a better chance of having the asthma under control. These are things you need to discuss with them. Honestly, you speak to them about it. Now, I want us to look at the current trend in asthma management. I mean, the previous presenter touched on that, but I'll just briefly say that regular or frequent use of SABA is associated with adverse effects. There's no place for SABA alone in asthma treatment any longer. As the 2019 GINA guidelines stated clearly. Short-acting bronchodilators, they provide fast but temporary relief of bronchospasm, but they do nothing to reduce the inflammation in the airways. Over-reliance on SABA is an increased risk of asthma attack and death. There's no, you can't say it's any milder or try to be politically, sensitive and right about it. You just have to tell your patient, if you are relying too much on your SABA, you stand a chance, a high risk of death from the asthma and from the drug you're using, all the side effects and everything. Everyone with asthma, even mild asthma, benefits from regular use of inhaled corticosteroids. The glucocorticoids are very effective at reducing inflammation in the body. They are the mainstay of what we call controller or preventer medication asthma management. The next slide, I'm not going to bother about it because it's been touched on already. That's the GINA guidelines. It's been touched on. So I'm not going to talk about those things. We know what they are. The step 1, step 2 for kids and adults and everything 12 years. We know all those things. So we just move on. Now, current, I want us to look at this. Is that my case 2? I don't know if it's case 2 or case 1. We just look at that. I think that's case 1, but I messed it up. So you have a patient who appears before you. A 30-year-old driver is at your pharmacy to buy a ventilator dose inhaler. This is his 5th MDI in a year. There is no other inhaler on his file. He also picked up some antibiotics and prednisone from your pharmacy a couple of months ago. The typical questions I will ask in that instance: what are you using the ventilator inhaler for? He tells me it's asthma. The question that I asked then: have you been diagnosed with asthma by a physician or a healthcare professional? A lot of people tell you they're asthmatic, but it hasn't been diagnosed. They will tell you, oh, my mother told me I have asthma. Or my friends tell me I have asthma. And they are on treatment for that. It hasn't been diagnosed. And I put a question mark there, diagnosed by a physician or a healthcare professional. Now, I have a spirometer at my workplace, which I use for my clinics. So you can easily diagnose asthma. I know we haven't gotten there yet in our practice in Ghana, but I believe that if you're going to set up and practice a pharmacy and be an expert in asthma, that is something we need to look at carefully. You may just use that to get your the graph and everything, and then you make a referral if you want to do it. And once we get to the point where we are prescribing pharmacists, once you diagnose the asthma, you put them under treatment, you just notify their physician. This is what you did with all the information. This patient was at my clinic, diagnosed of asthma, and this is the medication I've put them on, and you let the physician know so they can update your files. And you ask the patient, how many times you have these symptoms? And Kweku tells me, not every day, but when I need it. And he asks, how many puffs do you use daily? Over the last 4 weeks, how many have you used? And he tells me 2 puffs twice a day as needed. And then I'll proceed to ask him, do you use any other inhalers? He said, no. I had an orange one, but I stopped using it because it did not feel that it was working. It's a common thing you hear. So this patient was diagnosed 10 years ago. That's all he knows. And then, can you show me how to use the inhaler? Poor techniques. Not shaking the meter before using and did not breathe. So these are some of the basic questions you should be asking your patient about. All right, you ask them all these questions, and from there you can make some decisions. Now, after getting all this information from your patient, what are interventions you're going to make as a pharmacist? For me, intervention, he hasn't had a recent spirometry. He needs one. Using the asthma slide rule that I showed you, this guy is using 3 or more canisters per year, which means the asthma is not under control and he's a candidate for exacerbation. He needs counseling on that. There is no inhaled corticosteroids on his file, which is to help take care of the inflammation. He needs one. And what are his options? You work with the patient to pick one based on the GINA guidelines. He needs a flow meter, a peak flow meter, to monitor his asthma at home. He needs an asthma action plan. And with all this in place, as the pharmacist who is helping the patient, you need to follow up with them within 48 hours or 72 hours to find out how things are going. These are some of the inhalers we have on the market, several of them. Now, before I went on this thing, I have something I want us to think about carefully. So, assuming you have a patient, I'm going to use a hypothetical patient who presents to you a prescription from the physician for Ventolin and Symbicort for a 3-year-old child. As a pharmacist, you proceed to dispense the 2 drugs as prescribed without any questions. Now, this case I'm giving to you is something that happened, and I work with the patient to get the right medication for the child. The pharmacist went ahead to dispense the medication because it was prescribed by the physician. Ventolin inhaler and Symbicort for a 3-year-old child. That can be right. Now, so basic questions to ask this listener. No. So to begin with, the Symbicort for that 3-year-old child is not ideal. It ain't going to work. You need to use a lot of pressure to inhale your medication. That's a 3-year-old child has the ability with that kind of force to inhale the Symbicort. It's not working. The mother does not have a spacer. There's no aero chamber there. The mother doesn't want to use a steroid because of all the myth around that. The child doesn't have asthma action plan. So as a pharmacist, dispensing that medication to that child was not right. Not asking that mother if they have a space at home to administer the drug wasn't right. So many steps had been missed along the way. And I tell you what, so that patient, all right, the child was trying to give that Symbicort to the child. He was just also giving that child the Ventolin, but the asthma was out of control. Nothing was working right. So after having a chat with this patient, I mean, she lives in the Volta region somewhere around Keta. I got some medication right, got a spacer together. We put it on the bus for them to use. Within a matter of 1 week, the family was happy. That child was not having as many attacks as they were. And over a period of a month and a half, that child has not had any attack. Even though for the past several months to years, the child has been struggling. One, the physician made the wrong choice. But the pharmacist who dispensed the medication to that mother made a bigger mistake. You can't just do that because the doctor wrote the medication. No, it doesn't happen like that. In as much as the physician prescribed the drug, doesn't mean they have to dispense it. You have to ask questions. That symbol, you could have converted it into an ICS that will work for the child using a metered dose, using a spacer. In summary, the four essential components of asthma management are patient education, very vital, control of asthma triggers, monitoring for changes in asthma or lung function, and pharmacologic therapy. Asthma is not curable, but it's manageable. Using 3 or more reliever inhalers a year indicates a person is at risk of a severe asthma exacerbation, while the use of 12 or more is an indication that someone is at risk of asthma-related death. And you need to tell them, you can't mince words. Asthma control remains suboptimal due to low adherence, poor inhaler technique, and several patient-related factors. The patient's perception, socio-economic status, and health literacy influence asthma-related outcomes. Ladies and gentlemen, asthma can't stop me. We're going to beat asthma every day. Thank you for your time. Thank you.
Thank you very much, Prof. Ruto. We really appreciate your presentation. Thank you very much. We have some questions we want you to answer for us. The first question is, the question is, I want to read as it has come. Please, do we still use oral salbutamol in managing asthma? That's the first question. I want to read the second question so that we answer it at a go. The second question is there a tool for assessing control in adults? So we can take the first two for now.
Okay. Do you want me good to go or Dr. Nkansa will go?
Maybe ladies first.
I think this question has been answered in Prof.
In the
Wito's
presentations already.
presentation. I mean, Laura will give you more side effects and what are you managing? I mean, so I think it's all been said. It's inhaled corticosteroid. Throughout the presentation, when I was talking, I said you should hammer on the inhaled corticosteroid. It goes right into the lungs and then has the effect. And you should be using the steroids. I mean, so I think we've answered this question. The oral doesn't have a place. When you look at the general guidelines, it was at step 5. And that is even going to be used for a very short time. I mean, when the patient comes in emergency, and that's what the doctor would use. I mean, so it doesn't have a place in our pharmacies in managing these patients. It's been well thought out. Thank you.
Thank you. The third question here is, in the community pharmacy, affordability is a major challenge. You try convincing clients to pick ICS, but they complain of cost. Rather, they will do SABA every 2 to 3 days. What is your advice?
You know what? It's a tough situation we find ourselves. All right. Look, I practice in an environment where cost doesn't affect my what I prescribe or what I dispense. So I can understand where some people are coming from, some patients are coming from. But at the end of the day, now if I have a patient facing this kind of situation, we have to sit down and look at it carefully. Now, would you rather be using something that will kill you tomorrow? Or you will find the money to use something that will prevent exacerbations or attacks? Now, the truth of the matter too is that, look, some of those medications are on the NHSIS. Symbicort is there. A lot of people don't know about it. So as the pharmacist, you know that this medication is on the National Health Insurance Scheme. Why don't you advise the patient to get on the NHIS? And because the money they are spending to buy the asthma and all those things, that is enough to enroll them on NHIS. So they have access to medications that will help them. So you have the important role to play there where you advise them appropriately, they get on the NHIS, and then they can access all those medications because the medications are available on NHIS. So that is how I would approach it. But to begin with, I'll let you know, if you stick to that mentality that I don't have money, but I can afford asthma, I can afford this thing, you are on the path to death, or you are on the path of getting into the emergency where you're going to spend a lot more money on you and spending more time on you, time that the physicians or the emergency hospital, emergency medical staff could have spent on other medical conditions. And when it gets to that point, your family is involved, you lose job, you lose time for job, school, and all those things. So yes, it's a major concern, but we have a good role. We can get people to get on NHIs and get their treatment right.
Just to
Thank
add to
you.
it, just to add to
Oh,
that, I think that's where we have our patient healthcare practitioner relationship and also the communication skills. And we always think that, and we always say the patients don't have money, but ours is to educate them, empower the patient or the carer, and educate the patient, let the patient understand the disease condition, then the patient will know why he has to go, because he would realize that he will just be ending up in the emergency almost every time. If the patient doesn't understand the disease condition, he doesn't understand why he has to take the medication. So the disease condition is, and it's inflammation. What you are doing by giving the salbutamol is just going to increase side effects and not do anything for that patient. So it is very important that we understand it, we communicate that the patient has. That's why I think where Prof. Wuta was talking about, the video comes in sometimes for them to understand it, and then it becomes easier when you have to treat the patient. The patient will go and look for money and come back. And when the patients get much better, you've seen children who have grown out of asthma. When they get much better, they will always come back to your facility because they want to be treated. So it is very important that we have time for our patients and then educate the patients.
And Tiama, I try to avoid saying this, but look, if you have a patient who is who honestly and truly needs help, they can't afford anything, please I direct them to Asthma Ghana. I just try not to mention that here, but please direct them to Asthma Ghana. We should be able to help them there. Thank you.
thank you. The last question I read. Please, my question is in what stage can cough syrups be used to help relieve cough in asthma attacks? Example, Viscor F's cough syrup, which contains guaifenesin, salbutamol, and ambroxol. They want to know at what stage can.
Okay. So for the Viscov S, I don't know why you want to use for children. In fact, actually, in the hospital here, we don't use cough syrup in treating children less than 2 years. And for children, if you're treating them with cough syrup, you really want to find out what is causing the asthma. I think I talked about it earlier when we were looking at the symptoms that the patient has and other disease condition that can manifest as asthma. So you're not too sure, and then you're just using that to treat, because if you're using ambroxol, it's usually for the phlegm and the phlegm. And I don't know with the children. I mean, you want to look at that, and you're looking at the salbutamol, which we've talked about here. I don't see anything in that preparation that can be used to treat asthma. There's nothing for the inflammation in that treatment. So it's just I see that as placebo, if I should put it that way, and I don't see the need for the use in that patient. I don't know what Victor has to add to that.
Yeah, you just said it, but look, it's a placebo that has a terrible side effect. So I don't know. It has no place in the treatment of asthma. I mean, that's just going to be blunt about it. I mean, it's just a placebo that cause major problems down the line. Yeah, yeah. Thank you.
Thank you very much for the questions. I want to pass an announcement through that, as Rector said, tomorrow is the practical section. We start at 9 a.m. at UGMC. We have very limited slot for 50 participants. So if you want to make it there tomorrow, please click on the link and register. We don't want any disappointment. And just to thank you all the participants from all over, and our able facilitators, Auntie Amma, we affectionately call her, and Professor Awuto, and my able rector. Thank you, Ma, for giving me this opportunity to moderate this session. I am your humble moderator, Dr. Sinaka Abakizaki. See you tomorrow, God willing. Thank you very much.
Thank you also very much. God bless you.
Okay, so I think Dorcas has done my job for me. And so I'll just add to it and say thank you. And yes, everybody, make sure if you have, particularly for those who have already registered, make sure you are there on time. And if you haven't, this is your last opportunity to register because it is only by registration. Come in and let's do the hands on. I think all our facilitators have explained to us why we must know what to do, why we must know what to tell our patients. And so let's come in, have a feel of the devices so that when they are not getting it right, we can advise them appropriately. Thank you. very much to our wonderful facilitators and to our
Yes.
moderator. Thank
Thank
you.
you,
Thank
ma'am.
you, Rector. Thank you, Mobu. Bye.
Okay. Hey.